Hello and happy Thursday. Today's Thursday. It is Teach Me Tuesday on a Thursday, so happy Teach Me Thursday. My name is Lisa Houston. I am a neonatal ICU nurse, a NICU nurse educator here during February, which is Heart Month, and we're talking a lot about heart meds and heart diseases and heart processes during this month. This week, February 7th through 14th, is Congenital Heart Awareness Week. So on Tuesday, we reviewed the cyanotic heart defects, and today on Thursday, we are going to review the acyanotic heart defects. As we know, acyanotic heart defects are congenital heart conditions where the blood is shunted from the left, which is all nice and full of oxygen, over to the right, leading to increased pulmonary blood flow or some obstructed systemic blood flow. These defects can result in heart failure, pulmonary hypertension, that's a big one, inadequate systemic perfusion, and then overloading of the lungs. We're going to see a lot of these on fetal ultrasound, not all of them. The gold standard for diagnosing any congenital heart defect is going to be a postnatal echocardiogram, or echo for short. Sometimes these babies actually kind of outgrow them. They don't affect them for a long time depending on how big they are, and some of them just need a catheter closure. Others have a lot of surgeries to close. If you watched Tuesday's video, we've already gone through the normal blood flow through the heart. If you need another review, stay, listen. Otherwise, speed me up. Go 60, 90 seconds forward. But let's talk about the normal blood flow through the heart so that we have that in mind as we discuss abnormal blood flow. Our blood enters into our right atrium via our inferior or superior vena cava. This is the right side of my body. I don't know what it looks like when it's flipped for you, but this is my right side, okay? So my blood's coming in either from my inferior or my superior vena cava. It's coming in. It's deoxygenated. It did its job. It dropped off the oxygen, it picked up the carbon dioxide, and it is ready to get back to the lungs. It's going to go into the right atrium. It's going to go through the tricuspid valve into the right ventricle, up into the pulmonary arteries. As we've discussed, artery means away, so it's taking blood away from the heart and over into the lungs, where it's going to drop off the carbon dioxide, pick up oxygen because we want it to be full of oxygen, go into the pulmonary veins, go into the left atrium, the left ventricle, and out through the aorta. When you look at the aorta, this is our insider's tip. The color of the aorta is going to be the color of the baby. So if your aorta is nice and red, it might be a slight shade of purple if there's some mixing of blood. Then the baby is probably going to look pretty good and pink, right? Versus those diseases where the aorta, if you were to look at it inside, might be pumping out that unoxygenated blue-purple blood. The baby's going to look blue or purple. So keep that in mind as we talk about our different defects. The first acyanotic heart defect we're going to talk about is VSD. And for your trivia nights, or if you have an educator that plays Jeopardy with you, VSD, ventricular septal defect, is the most common congenital heart defect. It is a hole in this little septum that separates the two ventricles. You have a right ventricle and a left ventricle, right? So there is like a septum right in there. Depending on where the hole is going to affect the severity of your VSD. And this picture that we have here, there's a small hole kind of lower in your heart. It's almost a musculature VSD. Those are actually the least impactful for the baby, and you may not actually know that the baby has it. It may close spontaneously. Whereas other defects, especially the closer you get to your aorta, are going to be more profound. But regardless, this is going to shunt blood from the left side of the heart over to the right. So it's going to take oxygenated blood and put it over onto the right side where it is not needed. It can cause for more work to be on the right side and more blood flow to the lungs with oxygenated blood that the lungs don't need, because the lungs' job is to oxygenate the blood. Keeping that in mind, that is why these are considered left to right, because that left ventricle is the biggest pumper. It's the biggest muscle. It does the most work. There's more pressure over there, so the blood's going to flow from left to right across that VSD. These babies may require surgery, again, depending on how big it is and where it is. But for the most part, they're going to kind of not be a big deal, or they're going to close on their own. The baby could do well for years and then need to get it repaired when they're a toddler or older. Our atrial septal defect, right? So that means there's a hole between the two atrium. The VSD was between the two ventricles. The ASD is between the two atrium. This is often detected in utero. Again, your aorta is still going to be pumping out red blood. So when you look at your aorta, like I mentioned, for that quick tip in your head is if the aorta is blue or red, the baby is not cyanotic. The baby is still going to get their oxygenated blood. They may get slightly less oxygenated blood because it's passing over into the right atrium where it's not needed, because the right atrium's job is to take deoxygenated blood to the right ventricle and into the lungs. But the aorta is not really affected by this except for maybe getting slightly less blood. Again, these may close spontaneously, and they may require catheter-based surgical closure. This is interesting. I went to high school with someone that had to have a heart repair in high school because of exercise intolerance. So that's something that these are often diagnosed when people are older, especially if they're really small. Aortic stenosis. So again, your aorta is going to have a narrowing of the aortic valve, and that is going to have your outflow from that left ventricle. The big pumper of your heart is not going to be able to do its job because its straw is tightened or its pipe is clogged, right? There's just not enough room for it to go through. So when you think about that, your aorta is still pumping oxygenated blood, which is why this is an acyanotic cardiac defect. But it may do less, so that's something you need to think about. And so the baby's body may have intermittent periods of cyanosis, or modeling, probably more likely, as if they're not getting enough blood flow. The blood they're getting is oxygenated, they're just not getting enough of it. So something to think about. That's why these babies with cardiac defects are at higher risk for necrotizing enterocolitis. And the Neck Society just did a great review of this and had a post about it, which I will link to on my Instagram page if you want to follow us there. But it really can lead to issues with that because of the poor perfusion. And as you know, the body is always going to choose the major organs, the brain, the heart, the lungs, to oxygenate over things like the gut. So that's also why you're going to see modeling. These babies will get a balloon in there, and then they might need surgical intervention depending on how tight that stenosis is. So just think of different size straws. And the smaller the straw, the less blood that can go through. Pulmonary stenosis, same idea. It's the narrowing of the pulmonary valve causing right ventricular outflow obstruction. So your right ventricle is probably going to become hypertrophied because there's just too much blood kind of sitting down there, and it's having to work harder to pump it up into your pulmonary valve, into your pulmonary arteries, so it can get to your lungs. There's going to be like that backup on IL-3. It's going to have too much blood down there. You're going to have a murmur. You might have some cyanosis just because we're not getting enough blood to go in and get oxygenated from the lungs. And often this is diagnosed on prenatal ultrasound. Couple of things to remember that we've talked about. Yes, we may see these on prenatal ultrasound. We may not. That is why postnatal echo is the gold standard for diagnosis. We know that in the setting of multiple congenital anomalies in your heart, the more the anomalies, the more things that are going on. So keep that in mind. And just this idea of, yes, the baby may still be pink and well perfused and things may be going well, but the heart is going to work too hard, and that is going to affect the heart long term. And that's why we need to intervene in these cases and watch for these signs and symptoms. So an AV canal defect, an atrioventricular canal defect, is a combination of an ASD and a VSD and is often seen in infants with trisomy 21. We can see this usually on prenatal ultrasound because they're bigger. You're going to have a lot of pulmonary overcirculation, and you may end up in heart failure. These babies are usually poor feeders because their heart just kind of can't keep up with it. Again, if you look at this picture, right, the aorta is red. The aorta is still pumping out oxygenated blood. It's just that there's a lot of mixing, and a lot of that oxygenated blood is going over those defects, the ASD and the VSD together, and going into the right side of the heart where we don't need oxygenated blood because the right side of the heart's job is to go to the lungs. I'm hoping this repetition is going to help you all feel great. So we're watching for pulmonary overcirculation, right? Because now that right ventricle has blood that it shouldn't have, and it has to push it out to the lungs, and then surgical correction within the first year of life. Coarctation of the aorta is kind of one of those in-betweens that we want to be a cyanotic heart defect because severe cases do require PGE. We want it to be cyanotic because the baby can present with this, modeling and some cold feet and weaker pulses and can look cyanotic. However, the aorta is still pumping out oxygenated blood. So look here at the picture, right? The aorta is still nice and pink. It's just that enough blood can't get through. And depending on how tight your constriction is, this idea of what the coarc is a tightening and narrowing in relation to how tight it is and where it is in relation to your ductus arteriosus is going to tell you the severity of it. And I say that because if your ductus arteriosus is after your coarctation, you're probably still getting some mixing and there's still some pretty good blood flow. If it's before and your coarc is down here, and your ductus arteriosus is up here, you're not going to get that great blood flow. It's still going to be really tight. And that's why babies with severe coarctation of the aorta do need PG1 and will need that in order to maintain that ductal dependency to help that blood flow get through. So most likely your coarctation will happen before your ductus arteriosus. So you have your tightening, and then you have your ductus arteriosus, so there's still room for extra blood to get through. We're going to keep that open, so this is one of those acyanotic congenital heart defects that requires PGE, so that blood can still get through until we can remove this tightening or stretch the tightening, whether they're going to do that with balloon or they do this little thing where they pull it out and then just reconnect it. It's fascinating to watch videos on heart defect surgical repairs. So that's why coarctation can sometimes be a tricky one when thinking of, is this acyanotic or cyanotic? And that's why I come back to what color is the aorta. And your ductus arteriosus, right? Again, this is another one where is it cyanotic? Is it acyanotic? And it's acyanotic because your aorta is still pumping out that red blood. Our ductus arteriosus is required in utero. We need that to be open and pumping and allowing blood to flow through in order for our intrauterine circulation to happen. So we're going to be talking a lot about intrauterine to extrauterine transition, but that should then close, but it doesn't always. And in premature babies in the NICU, that is often something we are seeing, wherein that ductus arteriosus remains patent beyond what is considered normal. And that causes some left to right shunting across the duct, which means that the blood coming out of the left side of the heart is going to enter into the right side of the heart circulation. So again, oxygenated blood is going to go into the unoxygenated blood's pathway, which means to the lungs, which puts more pressure on our lungs. It can cause our lungs to be edematous and work harder, and it needs to be closed, which we usually do now, mostly with ibuprofen, still some indomethacin, sometimes some Tylenol. And then there are various ways to close it via a ligation, which is what I was doing for most of my career, but now they can do a coil. They're doing a catheter-based closure. There's also a lot of very interesting information on long-term neurodevelopmental outcomes in babies who do have PDA surgery and those who do not, and the outcomes are not actually that different. Something to think about. But we also want to say that it's cyanotic because we see a lot of shunting of blood as the bedside nurse in these situations where we have our oximeter on and it's telling us the baby is cyanotic, and we're seeing them cyanotic and we're seeing that their sats are low. And so it feels like that, but that's because of the mixing. And in those situations, most likely the right side is actually pumping blood into the aorta after the duct. And that's why we're seeing some of this right to left shunting instead of left to right. If you read your echo reports, it's probably talking about the way that the blood is shunting. So I put this on last because I did feel like this could be one that's like a little bit confusing as to is it cyanotic or acyanotic. It is still acyanotic because the blood that is flowing in the right and left side of the heart is correct. The left side of the heart is still receiving the oxygenated blood to put it up and out of the aorta. So it is an acyanotic cardiac defect. For our parents, this is just to build on what we talked about on Tuesday. We have a lot of emotional distress to this prolonged hospitalization. Some of these babies will go home with these defects, especially VSDs, ASDs, the acyanotic defects, they are more likely to go home. So we do need to talk to them about what that's going to look like at home. What are good feedings? How well is the baby eating? We will also need to talk about just like the emotional impact of rehospitalizations, prolonged hospitalizations, waiting for surgeries. They may end up with feeding supports such as G-tubes, feeding tubes, and they are of course at risk for infection. And then how can we support them with parent groups, maybe with other people that are going through this? I think there's such a great benefit in group support and group therapy and really being with people that understand what you're going through. I think we as NICU nurses do such a good job of supporting parents and using supportive language and how can we help them. But to be with people that really know what it's like to go through that is so important. So just like Tuesday, we have another great recap slide. This is just pulling all those acyanotic heart defects together on one slide. You can pause me. I will stop for a second. So if you want to pause and snip this. But yes, you can also email me at any time, message me here, and I will send this to you. Find me on Instagram, and we can get this straightened up. But this is just a quick recap. So as we know, acyanotic heart defects involve that left to right shunting. They've got obstructed flow. They can be diagnosed antenatally with prenatal ultrasound, but we always confirm with our gold standard of an echocardiogram. We have treatment that varies from watchful waiting to medical or surgical intervention. We want to make sure that we are taking care of their neurodevelopmental care, just like we talked about on Tuesday. All babies with heart disease and heart defects are at risk for having decreased blood flow, and so we want to their body decrease oxygen, right? Hypoxia. We don't want to have any sort of increased risk for that. So how can we best support them with our positioning, our medications, our parent support, having our parents at the bedside, doing skin to skin, regulating their temperature so that their body can really focus on the healing and getting the blood in the right places. And then, of course, we just want to make sure we're educating our parents on what long-term outcomes and benefits would look like for these babies. So thank you for joining me today. This week we did 2 big Teach Me Tuesdays. If you have any questions, please reach out to me. You can find me on Instagram or on TikTok or message me here on YouTube. I hope you have a great day, and I will see you next week for another Teach Me Tuesday.